As I said just before the break, I'm not an economist. My background originally is in behavioural science and psychology, and then subsequently trained in epidemiology and public health. So maybe some of the language I use and the concepts are maybe a little bit unfamiliar to you. Also, I would say as Illa just said to me before, the title here is different to what's in the program. It's kind of related in that I thought what I would talk about is some of the issues we are dealing with in the Australian healthcare system, which I think follows on very nicely from your initial comments, Illa, that the major health challenges for Australia really revolve around chronic conditions and how to deal with all of the consequential issues and impacts of chronic conditions on people, populations and health systems. And that I guess I'm coming to the view, as I also have experience of a lot of other health systems around the world and other countries, that the way in which we've traditionally conceived of healthcare delivery and our healthcare systems, and maybe some of the issues we were just talking about before the break, I'm not sure our traditional approaches and traditional systems are really fit for purpose for dealing with both healthcare delivery for chronic conditions and also, very importantly, prevention of those conditions, primary and secondary prevention. So that's kind of why I've changed the topic from improving NCD outcomes to talking more directly about the Australian healthcare system, but they're actually different sides of the same coin. I think my other sort of thesis is that I think then the role of government and regulation, also we need to think about that maybe in a different kind of way when we're thinking about chronic conditions from how we've traditionally thought of the role of government in dealing with infectious diseases and child and maternal health and the more traditional public health challenges. So some quick comments about background and context. I'll talk about some of the things which I think are quite good about the Australian healthcare system, and I'm sorry, Illa, for you, maybe some of this will be revision because you were just in Australia. How many weeks ago? Just a month ago, yeah. So you will have seen some of the good things. I hope you also saw some of the not so good things, but maybe I'll tell you what they are. But then I'll talk about the role of consumers and people, because I think it's the community perspective on this which I think ultimately is going to lead to disruption in the traditional ways in which healthcare systems have operated. And then there may be some final comments about perhaps also how this might change our view of public or population health. I come from University of Melbourne. For any of you who have been in Melbourne, this is an exceptionally good day, which is hardly ever like this in Melbourne, to have the sunshine. I can't remember all the weather when you were there, but did you get any of these days? Did you have good weather, or was it? Yeah, okay. Well, that was organised just for you. University of Melbourne is, along with Sydney University, is the oldest university in Australia. And what's most interesting about University of Melbourne is particularly where it's located, just very close to, University of Melbourne is, so the university is in the lower half of the screen where the greenery is in those old buildings, just on the edge of the CBD, but on the right hand side, as we're facing the screen, is a lot of the major teaching hospitals and a lot of the health science facilities and research institutes. So it's a very interesting kind of geographic area of the larger university and all of the health services and research institutes, which are kind of the interrelationships between the university, the hospitals, the research institutes and primary care and general practice networks. I'm in the the Melbourne School of Population and Global Health, and I'm director of that centre on the far right, which is the Centre for Health Equity, which interests unusually for a school of public health. My centre, the Centre for Health Equity, which is made up of actually economists and behavioural social scientists and historians and ethicists and all sorts of interesting disciplines, is actually the largest centre or department in the school, which is unusual because in most schools of public health it would be the Centre for Epidemiology and Biostatistics in the centre, or perhaps the Centre for Health Policy, which would be the larger department. So we have a very eclectic and diverse school of public health. As you know, Australia is a very small population, less than 25 million people, which is way less than many of your states here in India, of course. But it is a dispersed population over a very large country, although in saying that most of the population lives on the east coast of Australia, from about halfway up the east coast, which is Brisbane there, down to Melbourne and across to Adelaide, which is in the lower half and middle. So that's probably where about 70% of the Australian population live, in that sort of geographic area. We've got in Australia, we've got like here in India, we've got our national government, state government, local government, and very kind of complex interrelationships between those three levels of government in terms of managing different aspects of health. And given I've lived in Australia, not always lived in Australia, but I'm Australian, so I'm over the age of 60, but over 60 years I still don't really understand the Australian healthcare system and how it operates across all of the different levels, but I guess that's the same in all of our countries. And in the state of Victoria, which is where Melbourne is the state capital, we've got a Labor government at the moment, and I'll kind of come back to that later on, because some of the new initiatives related to population health and thinking about population health, I think in a much broader way than how we've traditionally conceived of that, is quite an innovation in the state of Victoria. So just a quick overview of the Australian healthcare system. So the really good news is if you rank Australia's health outcomes globally, you know, we do pretty well in terms of life expectancy, infant mortality. You know, one of the really stunning success stories in Australia's public health, as it is in the US and many Western European countries, is in addressing tobacco and smoking as a major public health issue. After World War II in Australia in about 1950, almost 70% of the Australian adult male population smoked, you know, which is one of the highest prevalence rates of smoking in any population in the world. But from 70% smoking, it's now down to less than 20% and 15%. So it's almost a reduction of 1 percentage prevalence point every year since the 1950s.
And women? A similar reduction for women?
Well, women have never been that high, so probably for women the highest it's ever been was probably 25%, about 1 in 4. But similarly, the rates in women now would be around 15% as well. So quite good. And here is the sort of graph that shows the national burden of disease for the top 10 disease groups in Australia currently. And as you can see, big competition between cancers and heart disease to be number one. But as you can see, between cancer, cardiovascular disease, mental illness and so on, chronic respiratory disease and stroke, these are the major causes of Australia's disease burden, and increasing levels of disability related to those conditions. So NCDs are the cause of probably almost 90% of deaths in Australia each year very rapidly ageing population in Australia. Healthcare expenditure, you know, interestingly, even though Australia's health outcomes are pretty good, the proportion of gross domestic product spent on health in Australia is round about 10%. So it's not as high as a lot of other countries, and particularly not as high as the US. So arguably, for the level of investment, the health outcomes are arguably, you know, pretty good. But if you look at where the funds are spent, you know, it's primarily on hospitals at the far left, pharmaceuticals next to the left, then medical services, which is the primary care system, and particularly general practitioners, who are the sort of bedrock of our system. The proportion that's actually spent on what we might call prevention or community health is really pretty small. It's you can see that that grey bar just column just above there. It's only just over 5%. So, and in fact, compared to a lot of other high-income countries, that's actually relatively low. So even though Australia's performance in terms of public health and prevention is pretty good, the level of investment is quite low, although it is quite difficult to calculate and work out those figures, because to define community health is quite broad and diverse. But as in most other high-income countries, you know, a big challenge for governments, of course, is just how much increasingly governments how much the increasing public expenditure on health, aged care, pensions, and all the kind of government expenditure that relates to those activity. And it's predicted that in Australia, there was just a report released in the last year that showed, at the current level of increasing expenditure across health and aged care, that's probably going to increase to something like 50% of all of government spending, and I guess that's the same in the US, isn't it? Something in that, which clearly isn't sustainable. So hence the need for kind of disruption of the system and the way in which care is provided for the increasingly ageing population and health. This is another one of those kind of confusing slides, which I was sort of suggesting before, in just the complexity of the healthcare system, and it's really difficult to explain this without being able to point. Can I go up to the slide? Yeah.
Your mic.
I can probably. I can't. Okay. I'm going to strangle you if I do that. So the message is that the major components of expenditure in the system are and I'll come to these later in a moment anyhow, the medical benefits system, which is what pays the doctors and the health professionals, the PBS, which is the pharmaceutical benefits scheme, are really the major costs in the system. And then there's this quite interesting kind of mixed model in Australia, which I think is why people from other countries often come to look at the Australian healthcare system, a kind of a mixed model of service provision, accountabilities, and contributions of funding from the government, what people pay through their private health insurance. And in Australia, if you have private health insurance, and probably about 50% of households have private health insurance, that can only pay for some very specific things. It can pay for going to a private hospital and some other very specific healthcare services, allied health professionals, and some other things. It only pays for those limited things. But then it's also the case that the out-of-pocket costs have been increasing very significantly over the last 10 years. So in the public sphere, it's the two major national subsidy schemes are the Medicare system, which is a form of sort of national public health insurance that we all contribute to as part of our salary every week. And then there's the pharmaceutical benefit scheme, which provides a subsidy for a list of approved medications. I can talk about those later on if people are interested. For the private health insurance, as I said, about 50% of Australian households have private insurance, and that if you have private health insurance, essentially what that entitles you to is that you can choose your own doctor or other health professionals, and you can choose your hospital. It doesn't necessarily guarantee you better quality care or a better hospital necessarily. I think people's perception is that it does, but the reality is, particularly for more complex conditions, arguably the bigger public hospitals and tertiary level university hospitals are probably better than most private hospitals anyhow, which tend to do the more high volume procedures and maybe less severe surgical procedures and so on. So that's kind of the good things. Maybe some of the not so good things. It is a pretty complicated system. The interplay between sort of the role of hospitals, specialists, general practice, all of the other community services, other primary care. I mean, these are pretty complicated, and the reality is for people with chronic conditions, they have to access all of those services, and the system kind of assumes that general practitioners are aware of all of those services and can really guide and help people, but research shows that in fact general practitioners don't necessarily or don't usually understand all of those interplay between all of those different services and systems anyhow, because usually they don't live in the areas where they practice and they're not using those services and they don't necessarily understand them all. So one of the questions we look at a lot in our research is then, if you have a chronic condition, then how can you kind of navigate the system and understand what all of those services are that you need? And also, as you become older and maybe increasingly frail, the paradox is you probably need to access more and more of the services with perhaps not having the same kind of abilities to access all those services. So it's kind of a paradox. So this is kind of the reality, I think, for many people with chronic conditions. If people have diabetes or heart disease, mental health conditions, or often all of those things together, is, how is it possible to kind of negotiate and access all of the different services and systems that you need? Because if you look at the top half of the slide, on the left side, you need to regularly access primary care, you need to access on occasions specialty care, on occasions you'll be accessing acute hospital and outpatient care, and then as you become older, then you probably then will have a need for aged care services, maybe services coming into the home care services. So really within our system, there's no one to help you do all of that stuff that you have to do by yourselves. And maybe in times gone by, you would have had family members or others to help you do that, but increasingly older people are having to do that by themselves, and often by that stage, once they get into their late 70s and 80s, often they don't have a partner, so they're trying to do all of that by themselves. So that's that's a part of our health system which doesn't work at all well, I would say. So the way I kind of think about it, and I do a lot of research related to diabetes, both prevention but also developing kind of new approaches and systems for helping people to better manage diabetes and technologies and health and so on, is that 8,766 is the number of hours in a year. For someone a typical person who's reasonably well managed with diabetes, maybe you spend about 6 hours going to see a health professional. So it's only a tiny proportion of hours, and probably most of that you're actually not seeing the health professional, you're waiting in the waiting room to see the health professional. That's another thing. But all of the other hours, the other 8,760, you're on your own, and with all of that other time, you're managing your diet, your medications, you're monitoring blood sugar, insulin. If you're working, you're having to manage taking sick days off from work, and as well as all the other kind of psychosocial challenges. So this is kind of complicated and challenging, and this is something that our system doesn't do very well, and arguably, I don't think there's any healthcare system in the world that kind of does this particularly well, and it can't do it particularly well because I think maybe our workforce isn't quite appropriate for kind of managing these kinds of conditions, and our traditional approaches to healthcare delivery, and particularly for acute care delivery, don't really work so well for providing care, delivery and prevention for chronic diseases. So we've got health systems which have developed over 50 years or more, but are they actually fit for purpose for the kinds of health conditions that we're trying to kind of manage? And that's why the time I spend in China and India and other countries, I kind of say, well, if you're actually looking at reform and developing your systems, then I think it's really a good idea to kind of look at a lot of the lessons and learnings from high income countries and things that we're not doing very well, rather than assuming that the models we've got are going to be appropriate for what you're trying to do. So the question I ask myself is whether there's a need for a really significant sort of paradigm change and the models that we use, and what's going to cause that disruption. And I think that disruption, as I see it in Australia, for example, is already beginning to happen, because people with chronic conditions already access a lot of self-care resources and supports for self-care. They use a lot of not-for-profit kinds of organisations to help them, and a lot of other networks. And these are in addition to the formal healthcare system. So if I kind of think about it, I almost want to turn the system upside down and really think about how we can give more value and support and really enable a lot of these other services and supports. So someone has called this sort of the bottom down health system, if you like, turning it upside down and really giving much more support to the self-care resources and supports to disease prevention and primary care, rather than what we typically do, which is focus much more on hospitals and the traditional health and medical care services. If we think about that within a sustainability paradigm, then clearly the three things that we are classically trying to do, we're trying to reduce the burden of disease, we're trying to reduce inappropriate demand for care, and we're trying to manage the supply of care efficiently. And a large component of that related to chronic conditions is really that self-care component. And my thesis is that we don't give nearly enough care and thought and consideration to what are the kinds of resources and supports and services we really need to provide to people to better self-care and to better self-care within their normal lives and within kind of the community context. Because if we don't do that well, that of course is what leads to a lot of preventable rehospitalisation, a lot of additional dependence on the healthcare system, And then with older people, that's eventually what leads to people going into aged care and other hospital services, which then of course become a very significant cost for the healthcare system and the society. I was just going to say the other aspect of self-care is that it not only relates to better management of chronic diseases, but it also relates very importantly to preparing individuals, families and communities for the end of life, and how that can be managed I think in a more humane way in all of our societies, but also in a way that arguably wouldn't cost the healthcare system as much as it often costs at the moment. So then my question really is this one, which is, how's it possible to achieve disruption or big change to our traditional models of care delivery, but not just models of care delivery, it's also the workforce that we've got. If we actually got the right healthcare workforce that's fit for purpose for the kinds of health conditions that we're trying to manage, and what's the role of technologies in really both sort of aiding and abetting that disruption, but also coming up with solutions and innovations which are going to be able to help people better self-manage chronic conditions. I wanted to now just spend a few minutes talking on some research that we did a few years ago, which really came to this point of, well, if we talk to people in communities, what do they want, and what do they think would help them better self-manage these complex chronic conditions, often with very complex comorbidities. And this was part of work we were doing as part of a national institute that I was the director of, which was the Australian Institute for Health Policy Studies, where we were really focusing on consumers and populations and consumer engagement, and collecting evidence from communities that we were working with, and then combining that with clinical guidelines and evidence that we had about how healthcare could be delivered more effectively, and then sort of putting those two things together with policymakers and decision makers to see if we couldn't come up with some better community-based models and approaches to address some of the issues that I've been talking about for the last 15 or 20 minutes. And one of the ways we did this was by running what we called deliberative engagement. So having meetings with communities all around Australia, presenting them with scenarios of health issues and getting them to make suggestions about how they thought their communities or their health services could better address those kinds of challenges. And we had a whole approach to developing these deliberative processes of engagement, which were much more than just consultation. It was actually developing, what we did was we actually developed scenarios which we then met with communities over a couple of days, presented them with scenarios for different kinds of health issues related to chronic conditions or mental health problems, and presented them with data and information in a very lay way, and really encouraged them and enabled them to come up with ideas and solutions for addressing those points. And in this particular engagement meeting we had with the community in a rural community in Australia, we presented them with budgeting challenges. We presented them with a scenario of health issues and challenges where, the 80% of the disease burden in this community was related to chronic conditions, and gave them a budget for how they might, funds that they could spend in whatever way they chose to address that issue, and got them to give suggestions and example. And here were the example, and here were the suggested strategies that came from this particular engagement process. It was about setting up a network of community-based wellbeing centres and health clinics in the community. So very primary care based, but also a bit separate from what general practitioners traditionally do. This community was very supportive of focusing more on prevention and giving more funds and training people from the community to undertake health checks and identifying opportunities for prevention, through the life course. They also identified ongoing and improved education and promotion and regulation about reinforcing healthy choices and how to address risk factors related to chronic conditions. They also talked about the need for programs in workplaces as well. And a lot of the discussion, and I was thinking about this slide in relation to the presentations before the break, was about, what's this relationship between individual behaviour change and what individuals and families should do for themselves versus the role for regulation. And I don't know about in India or in the US, but certainly this is always a very kind of contentious issue around, what governments should be doing and what people should be doing for themselves. But actually I've always found when having these kind of deliberative sessions and discussions in communities, it's always a very reasonable discussion actually. It's all people actually acknowledge the things that they need to do themselves, but really seeing the importance of policy and regulation as a way of reinforcing and helping people to make those changes. And tobacco control would be one of the best examples of that. We also, in one of these groups, had a very good discussion about health records, because this is all electronic health linked records, because this is also a very contentious issue in Australia. And again, I've always found when this is discussed in communities, it's always a very reasonable discussion about people seeing that the need for electronic linked health records, if there's a good argument for how these can be beneficial for health, then people's concerns about confidentiality and privacy aren't nearly as significant as often is discussed in the kind of political realm. And then finally, I thought I would just make a couple of comments about how these ideas maybe sort of feed into thinking about population health in a different way. And I think traditionally, these 8 points here related to population health, I don't think any of these are particularly controversial. I think we've been talking about these for years, focusing on the health of populations, addressing the social determinants, using evidence, working upstream, using multiple strategies, collaboration across sectors and levels, etc. I don't think any of those points are contentious. But one of the ways in which some of our research is really bringing all of these concepts together, but also relating it back to prevention, health promotion and addressing chronic diseases, is thinking more about livability and people's living environments. And I thought, I was thinking about this in relation to your introductory comments about, pollution as a big issue, that really, as we come to understand more about all of the linkages and interplay between the kind of downstream, the midstream and the upstream kind of causes of chronic conditions, we realise more and more that these are outside the traditional health realm, and they are related to people's living environments, the quality of air, the quality of food, the food systems and the food supply. So understanding kind of livability within that broader context and urbanisation, and how people can be more physically active and their living environments, their access to public transport, all of these things are very, very interlinked, and ultimately at the downstream level are very related to chronic conditions. And this, I think, is a framework for also thinking about sort of chronic disease, which also gets people thinking more broadly than just the traditional healthcare delivery system, which isn't really able to deal with the challenge, I would argue. And just finally, we've been doing quite a lot of work with the World Health Organization, and we've just developed this new monograph, but it will also have a lot of other resources, which is really talking about the need for doing a much better job of what we call implementation research. So really understanding more about how policies, procedures, regulations are developed, designed, implemented, redesigned, further developed, implemented and scaled up, and doing kind of more research in that realm, because it seems to me that a lot of the things that we need to do in healthcare systems and a lot of the things which can be helpful for prevention and promotion, we kind of know the what's to do. We know what to do for tobacco control and so on, but it's really about, it's the how-to things, and it's the how-to things that I think we can learn much more about, thinking about in this kind of implementation research cycle. And that also speaks to the issue of understanding what to do when we move between different countries and cultures and contexts as well, where there obviously has to be significant refinement to kind of implement and adapt in different contexts and settings. So in summary, I know I've kind of talked a lot and covered quite a bit of terrain, but my learnings, I guess, from Australia and other healthcare systems and countries I've been going to a lot over the last 10 years is, to address the kind of NCD epidemic, both prevention and management, I think we have to look for some disruption and ways of dealing with these challenges in different ways, because I don't think our traditional healthcare systems can do this as well as we need to. And for that to happen, I think there has to be disruption of the way we do things. And certainly in Australia and what I'm seeing in other countries, this disruption is coming from citizens and consumers, because they want to self-manage their diabetes, they want to manage their heart disease and all the comorbidities and mental health issues, and they realise that the traditional healthcare system can't do this. So they're actually drawing on other resources and supports and using new technologies and mobile health and so on as ways to do this. I think the responsibility of the system and government then is to think about how a lot of that can be better systematised, and potentially that requires regulation, so that we can then kind of develop new approaches to improving the health and well-being of populations. Thank you.